Good evening, everyone. Today we'll be seeing the fifth case in the radiology case series. So this is a 15-year-old girl who presented with frequent history of falls in the last 2 months. These are MRI dorsal spine images, T2 axial images, and the stir coronal images. Here we are able to see a well-defined mass lesion which is seen within the intradural extramedullary compartment. This T2 hyperintense curvilinear structure which we see is the dura. So the mass lesion is seen within the intradural compartment. It is outside the compressed thoracic spinal cord. This is a thoracic spinal cord which is relatively normal with mild flattening in a more cranial image. And as we keep moving caudally, we are able to see that the mass lesion is causing compression of the thoracic spinal cord and displacing it laterally. Stir coronal images confirm the same finding, that the mass lesion is attached to the dura with a broad base towards the dura, and the medial part of the lesion is causing mass effect, causing compression of the thoracic spinal cord in the mid dorsal vertebral level. Diffusion weighted images and T1 axial images shows that there is no T1 hyperintensity within the mass lesion, and there is restricted diffusion which is seen within the mass. In post-contrast sequences, we are able to see that the mass lesion is showing homogeneous post-contrast enhancement. There is a dural tail which is seen attached to the superior part of the lesion, and there is a dural tail which is also extending in the inferior part of the mass lesion. On closer inspection, there is also subcutaneous well-defined T1 hyperintense enhancing mass lesion which is seen in the subcutaneous fat overlying the thoracic spinal cord. It is also noted here. In the axial images, again, the intense post-contrast enhancement and the relationship between the tumor as well as the thoracic spinal cord is seen. The thoracic spinal cord has been displaced and compressed towards the right side by the mass lesion. Lumbar spine screening shows multiple nodular enhancing intradural extramedullary deposits or nodular mass lesions which are seen in the entire part of the cauda equina nerve roots. These lesions also show T2 hypointensity. Cervical spine, again similar findings. There are multiple enhancing lesions. This particular mass lesion is better visualized, which is sitting on the pial surface of the cervical spinal cord at C2 level, again showing homogeneous post-contrast enhancement, and it is showing a T2 hyperintensity. More laterally in the subcutaneous fat, again we are able to see a well-defined lobulated soft tissue mass lesion which is seen in the subcutaneous fat, showing homogeneous post-contrast enhancement. As we did a screening of the MRI brain also. Here we are able to see that there is a nodular lesion which is seen at the internal auditory canal on the left side. Also on the right side we are able to see that there is a thickening which is seen in the internal auditory canal along the right 7th 8th vestibulocochlear nerve complex. We picked up this particular enhancement in the post-contrast image, which led us to do a BFFE sequence which was shown earlier. So there is an enhancement which is seen within the temporal bone. So this is along the course of the 7th 8th nerve complex, extending into the cochlea as well as in the semicircular canals. The coronal images, again we are able to see the enhancement which is seen within the bilateral internal auditory meatus extending into the vestibule as well as the cochlea. This is an abnormal enhancement. We never usually see any enhancement which is seen within the 7th 8th nerve root, nor do we see any enhancement of the cochlea or the vestibule. So this is an abnormal finding. The reason why we see this abnormal finding is because that there is a intralabyrinthine and a intravestibular schwannoma which is present in the bilateral 7th 8th vestibulocochlear nerve complex. So to summarize the list of imaging findings we have seen so far, in the thoracic spine there is a well-defined intradural extramedullary mass lesion. It is severely, it shows T2 hyperintensity. On CT screening, there was a calcification which was seen within the mass. It caused severe displacement and compression of the thoracic spinal cord, which explains why the patient had frequent falls. There was no flow void, and there was an intense enhancement. This flow void is very essential because many of the schwannomas, meningiomas can show intense enhancement. But if we see a flow void, then the differential moves to other things like paragangliomas or hemangioblastomas. Though all said and done, Hemangioblastomas are intramedullary lesions, and this is an extramedullary lesion. The clinching finding towards this patient was the presence of dural tail. So the lesion that we saw in the thoracic spinal cord correlates with the meningioma of the thoracic spinal cord, which is causing compression. The lesions which we saw in the cervical and lumbar spine, that is a multiple small enhancing T2 hyperintense lesions which were studded throughout the conus medullaris, cauda equina nerve roots, and in the pile surface of the cervical spinal cord, were basically schwannomas. They didn't show any calcification. So how to differentiate between meningiomas and schwannomas? Both of them will show intense enhancement. Both of them will be intradural, extramedullary. But if you see a dural tail, then it favors a meningioma. You see calcification, which is seen in majority of the patients, it favors a meningioma. Whereas schwannomas rarely show any calcification, nor is there a dural tail which is present in these patients. Brain lesions, there are bilateral, vestibular, and intralabyrinthine schwannomas which are seen. Other findings that there were also subcutaneous schwannomas which were seen in the nape of the neck as well as in the posterior surface of the body at the level of the meningioma. So coming to the diagnosis. So this patient has bilateral intravestibular bilateral vestibular schwannomas. So the diagnosis is straightforward. It is a case of neurofibromatosis type 2. Neurofibromatosis type 2, the diagnostic criteria has undergone modifications recently. The last modification came in 2018, in which if the patient has a bilateral vestibular schwannoma, or if the patient has a unilateral vestibular schwannoma, then either he has a first degree relative with NF2, or if there is a two of the following tumors, basically meningioma, non-vestibular schwannoma, ependymoma, or cataract, and a first degree relative, then the patient has a neurofibromatosis type 2. This is called the revised Manchester criteria. Simplified version is given here. Bilateral vestibular schwannoma, straightforward. You don't need to look for anything else to prove it to be a NF2. If you see a unilateral vestibular schwannoma, then you need to look for other tumors. You see multiple meningiomas, again you look for unilateral vestibular schwannoma and you look for other tumors. If there is a first degree relative with NF2, then these are the findings that you look for. So in NF2, there is meningiomas, there are schwannomas, there are ependymomas, and there is cataract. So this is again the summary of the findings, that these are the three important tumors which are seen in neurofibromatosis type 2, schwannoma, meningioma, and ependymoma. And our patient had bilateral vestibular schwannomas, meningiomas, as well as multiple cutaneous schwannomas, as well as intradural extramedullary schwannomas of the spinal nerve roots. The article from Radiographics is it's a very good article which helps us in summarizing the various findings in neurofibromatosis. It lists the findings in neurofibromatosis type 2. Here we are able to see bilateral vestibular schwannomas as well as Meckel cave schwannomas, which is causing compression of the bilateral cavernous ICA. This is peripheral nerve sheath tumor, dumbbell shape. There is a extra paraspinal component as well as a small component which is seen in the intradural extramedullary space. This is a T2 sagittal sequence in which we are able to see T2 hyperintensity, which is showing multifocal enhancement suggestive of ependymoma. Here multiple meningiomas are shown in this particular image, and this is multiple schwannomas which are seen at the level of the lumbar vertebral level. One of the interesting things that we saw in this patient was the intralabyrinthine schwannoma. Vestibular schwannoma is something that we commonly see, that there is a widening of the porus acousticus, and there is a soft tissue component or a soft tissue mass lesion which shows homogeneous enhancement. What are intralabyrinthine schwannomas is? These are schwannomas which are purely within the internal acoustic meatus, which are either involving the cochlea or the vestibule or the intravestibular part of the 7th-8th nerve complex. So there is an article in the net. This is called as intralabyrinthine schwannoma, imaging, diagnosis, and classification. It divides the intralabyrinthine schwannoma into 6 variants. So if only the cochlea is involved, it is called an intracochlear intralabyrinthine schwannoma. Here we are able to see the vestibule is showing a small tumor which is showing enhancement. So this is the intravestibular variant. Here what we see is a vestibular as well as a cochlea. There is both the vestibule as well as a cochlea is showing enhancement as well as soft tissue component. So this is a vestibular cochlear variant. What we see is a transmodular because the modulus of the cochlea is involved. So this is a transmodular. This is a transmacular where the vestibule with an extension into the internal aortic canal is seen. So this is a transmacular variant. This is a transaortic variant where the labyrinth, that is a cochlea, vestibule as well as the internal acoustic meatus is involved. These are the 6 variants of intralabyrinthine schwannoma. Intralabyrinthine schwannoma is a different entity when compared to the normal vestibular cochlear schwannoma which we see, because this is purely within the bone and you should take specific uh, precautions to look for the enhancement which is seen at the cochlea, vestibule and at the root at the apex of the 7th 8th nerve complex to identify this particular tumor. So coming to the next question, what do we do with this patient? What is the imaging recommendation? When do we need to do an MRI brain and MRI spine? So the recommendation is annual MRI of the brain with and without contrast. So the decision whether to give contrast can be taken. For example, if you already have a patient in whom we know what are the locations in which the tumor is, and we are just monitoring for any increase in size, then maybe we can do it without contrast. Only for documentation of the size, that would be sufficient. But if it is first time diagnosis or if there is something specifically that we need to look for, then it is better to advise contrast study, because all said and done we need an annual MRI for this patient, and this is a 15-year-old girl that we are talking about. Coming to the spine, MRI of the spine is done with and without contrast every 3 years if there are no spinal tumors, and every 5 years if there is spinal tumors every 3 years, no spinal tumors, then it is 5 years. So what to do with these things? Only if they are symptomatic, they undergo surgical resection, because there are multiple tumors in this patient. So there is really not much of point in doing a surgery for asymptomatic patients. So to summarize the other intradural extramedullary spinal cord lesions, so we have seen meningioma, schwannoma, other thing is neurofibroma, malignant peripheral nerve sheath tumor, leptomeningeal metastasis, solitary fibrous tumor, and myxopapillary ependymoma. So whenever we see this extensive intradural extramedullary nodular lesions as in this patient in the cervical and lumbar spinal cord, leptomeningeal metastasis is one thing that we'll have to look for, because it shows typical nodular enhancement, and leptomeningeal metastasis sometimes will be picked up in MRI even if the CSF analysis is negative. So MRI with contrast is a better modality to identify leptomeningeal metastasis, and in case if the patient has a leptomeningeal metastasis, the prognosis is actually very dismal. So you need to always look for the rest of the body to see if there is any primary malignancy which has metastasized to the spinal cord. In our patients, the clinching point was bilateral vestibular schwannomas or intralabyrinthine schwannomas as in our case. So leptomeningeal metastasis was ruled out in this patient. Thank you.